now. So,
Brilliant. Glad to hear it.
right. Okay, so I'll just pull up my slides here. Okay. Can you see my slides?
Yep, that looks perfect. Thank you.
Okay, great. So this is so today I'm going to talk about a project I worked on almost 4 years now. When I was a postdoc at Yale University School of Public Health, with my along with the co-authors you see here and my supervisor, Dr. Ted Cohen. And essentially, as Finn had said, we looked at different spatially targeted TB screening interventions in Lima, in a district in Lima, Peru, and using a sort of an individual based modeling framework. I'll just give some sort of brief motivational background. The WHO estimates that approximately 37% of incident tuberculosis cases are each year go sort of undiagnosed and untreated. And it's been proposed that a potential way to kind of find these new cases to prevent onward transmission as well would be to conduct more sort of active case finding interventions. I think probably most people know this here, but just to highlight, so in the standard and high burden settings is remains sort of passive case finding, in which people come to treatment by on their own they sort of self-present to treatment. Active case finding in general sort of aims to minimize this burden and reliance on patients self-reporting for treatment, and really aims to sort of seek out new cases of TB in the community. And there's different kinds of active case finding interventions, but in general in the literature, there's been various trials and studies, and the results have been somewhat mixed. So for instance, there was a SAMSTAR study in Southern Africa that looked at a couple different interventions, and one of the interventions was this sort of an enhanced case finding, which included things like more access to diagnostics, community mobilization, but in fact there was actually sort of in this particular trial, it was found to be there was a null effect of this sort of community-based enhanced case finding. Another trial, on the other hand, this Detect TB trial, I believe, was in Zimbabwe, and looked at what sort of more targeted kind of door-to-door treatment case finding, and here there was sort of more of a pronounced sort of effect on TB prevalence that was it turned out to be statistically significant. So all this to say, there's many different kinds of active case finding interventions, but and various trials have been conducted, but they've sort of have yielded mixed results on sort of overall TB epidemiology in different communities. To give to go into more sort of specific spatially targeted intervention details. So basically, there's sort of very highly targeted interventions, which again, I'm sure most people know this here, like household contact tracing, and those have been proposed as very sort of efficient ways to find new cases. Basically, if there's an index case in a house, you test everyone else in the house and to way to find sort of previously untreated cases or unfound undiagnosed cases, but they sort of seemingly seem to only sort of result in modest population level reduction in TB incidence. And so there's sort of also an absence of empirical data when we're talking about spatially targeted active case finding interventions. So there have been some modeling studies about this, and they've found that if you sort of target sort of higher level, let's say hotspot areas, so neighborhoods or areas where there's a high prevalence or incidence, that could potentially have widespread community level effects on TB epidemiology. So this is an example of one of the modeling studies. This was by Dowdy et al. Basically it was a compartmental model based in Rio de Janeiro, and they found indeed that if you could sort of target these hotspots and normalize the transmission in the hotspots to sort of the same level as what's going on in the throughout the community of the rest of the community, then it could lead to sort of substantial levels of reduction in TB. So this was, as I said, a compartmental model, which has certain assumptions about homogeneous mixing and everything. So we wanted to sort of explore how potentially I should also mention about the Dowdy work that it was sort of dealing with sort of large numbers of large levels of high populations. So these interventions in the model were sort of given to many people at the same time. So we sort of wanted to sort of continuing on this theory that targeting quote unquote hotspots would yield large reductions in TB incidence. We wanted to sort of explore how potentially smaller scale interventions would perform in a model with sort of a very detailed representation of the spatial distribution of TB. So I'll jump into the methods now and the setting and everything and sort of go into the details about the model and the calibration. Basically, we had prospective cohort data from this study in Lima between 2009 and 2012. To sort of simplify the problem and make making sort of more computationally feasible, we only focused on one district in Lima. Basically, this prospective cohort study had sort of mapped TB cases over a 33-month period. In Lima during that time, we picked sort of the highest, the most densely populated district in Lima in that study, which is San Martin de Porres. So the population is about 600,000 individuals. And so so on the right is the distribution of the cases. They've been kind of jittered so to avoid sort of identifiability. But the approximate distribution of the cases over the 33-month period in this district, and on the left is the population density in San Martin de Porres. So basically, for the model setup, this spatial individual-based model setup, first we sort of recreated this population density. So this data, I should say, the population density is from WorldPop, and basically how it works is it's divided the district into like grid cells that are 100 meters by 100 meters, and the average population in a grid across all grid cells was about 140 people, and so basically what we did is we kind of recreated this population density as sort of the initial sort of spatial the setup of sort of the spatial component of the model, yeah, so that was sort of the first step, and we made a kind of a simplifying assumption that all the individuals were located at the centroid of each cell, because we didn't have actual sort of household locations, and just also to simplify to make it sort of more computationally feasible as well. Okay, so now on to sort of the natural history model structure of sort of the TB transmission model structure that we sort of layered on top of the spatial distribution. We have sort of we have 6 key states disease state. So, susceptible people can become infected according to the force of infection, which I'll describe in a minute. And once they become infected, they enter this early latent state that lasts for up to 5 years. And if they don't progress to active TB, which is represented by I, they pass into this late latent state where the rate of progression from late latency to active TB is much lower. So individuals who have active TB, they can transition to a treated state in which they're assumed not to be infectious. And that's in the model, that's what will represent case notification. So when people transition to treatment, it's as if there's like a case notification. They can also sort of spontaneously recover, or after treatment, they can recover. And I'll just say, people who are susceptible and early latent, late latent, or recovered can all become sort of reinfected and move back to the early latent state. Okay, so moving on to the force of infection. So really, basically, yeah, it's an individual-based model. So each individual's force of infection is sort of quantified separately. It's really a combination of household contacts and community contacts. So I should have said, let me just go back and clarify something. Basically, we sampled for each grid cell in the population density, when we were recreating the population density of the district, we sampled households. So different household sizes and the distribution of household sizes was in line with published data. Basically we've had access to sort of Peru level household distribution sizes. So we recreated that distribution. So basically people are in households, and each household, and so each grid cell might have let's say anywhere from 5 to 20 households, or maybe even more, perhaps even more. And they're all sort of assumed to be located within that same grid cell. So back to the force of infection. It's really a combination of sort of household contacts and community contacts. Individuals, so the first line represents sort of the household force of infection, which is really just the household transmission rate multiplied by the number of infectious contacts that an individual will have in the household. So if they have 4 household members and one of them has active TB, then it's multiplied by the household transmission rate. So the community transmission rate is sort of the next component, which factors in sort of spatial proximity so if we're talking about one susceptible individual in question, we calculate the community force of infection by taking the community transmission rate and multiplying that by basically, if say there's one infectious person, so basically we calculate the distance between the susceptible individual and the infectious individual, and that's this Li minus Lj. It represents the Haversian distance. So the distance between the susceptible person and the infectious person is taken into account. And then there's also this, it's raised to a power. So this is a power law kernel. So the reason why we chose this is because it's been sort of shown to represent human mobility patterns. So there's sort of a quick, basically, it allows for sort of spatial interaction or interaction between people who are very far apart, but it's less common. There's sort of more, you can have sort of, you're more likely to have interaction between people who are very close together. So there's kind of a fat, kind of like a fat tail, but a long tail. And there's also one other component of this community force of infection is this theta metric, which puts sort of imposes a limit in spatial interaction. So and we varied all of these parameters and you know to see which ones fit the best. But in some parameter sets, this limit was set at say 5 kilometers. In other ones, it was say 14 kilometers. But we varied all of these parameters, and I'll go into more detail about the calibration methods and how we varied the parameters in a second. But basically, to calculate sort of the final force of infection, you sum the household force of infection and the community force of infection, and then it's sort of modulated by the state of the individual. This is so if the individual is recovered, then they have some immunity, but if they're fully susceptible, then they don't. Okay, so basically onto the sort of the calibration methods. So we ran the model with 10,000 different parameter sets to steady state. This is just sort of a high-level overview of the calibration methods, and I'll go into more detail in a second. And then so we varied a lot of those parameters that I was talking about before, like the theta and the power that we raised the distance to get that to calculate that power law. And so again, we ran the model on 10,000 parameter sets to steady state. We then determined how well each parameter set matched the local intensity of cases. So we calculated a likelihood, and then we sampled 2,500 times with replacement using the likelihoods as weights. So this is sample importance resampling. It's a good way to get sort of a distribution of more feasible parameter sets. And so if one parameter set sort of matches the data really well based on these likelihoods, then it might be resampled more times and have a sort of be represented more in the final array of parameter sets. So I'll go into detail about the likelihood calculation. So for basically for a given parameter set, we had sort of, you can imagine we had a map with cases, right, that were mapped based on latitude and longitude. And then we smoothed the case notifications in the model and using KDE, kernel density estimation. And that really provides an estimate of the underlying probability density function. So basically, what this means is in regions with more cases, the KDE estimate is higher. In regions with fewer cases, it's lower. And so we generated a KDE from the model and a KDE from the data set that we were matching the model to. And this was really the goal of the calibration, was to sort of recreate the local intensity of cases. So to recreate sort of clustering of cases in different parts of the district. Going back to so we have a KDE from the model, and then we have a KDE from the data, and then we compared them using this Kullback-Leibler divergence, which basically is just essentially quantifies how much information would be lost if we were to approximate the data KDE with the model KDE. So just to kind of hammer this point home, in a very kind of simplistic example, if we have sort of cases, let's say over time, you say in the blue, the blue plot, we can sort of, we can smooth it using a KDE and say that's the data, and then we have sort of model generated, similar model generated plot as well, and then the KLD just kind of compares the two. Okay, and just to kind of provide more of a summary, because I think these calibration methods are sort of rather complex. Basically, what we did is we sampled 10,000 parameter sets using Latin hypercube sampling. We ran the model to steady state plus 1,000 months, and we ran it to steady state because we didn't know the age of the cluster of the cases in San Martin de Porres. So we made the assumption that it's especially for reproducibility purposes, it's better to run it to steady state. Then we ran the model to steady state and longer. And then we sort of derived the KDE of the spatial distributions, distribution of case notifications from the model. And we compare and the data as well. We compared the two using the Kullback-Leibler divergence. And then we used the Kullback-Leibler divergence, the KLD, as weights to resample which parameter sets best recreated the data. And again, the goal of this calibration was to recreate kind of the local intensity of cases and the clustering of cases throughout the district. So I'll go on. I'll talk about the spatially targeted interventions that we looked at. So first we did of course basically the model run without interventions was assumed that passive surveillance always was occurring in the background. Then when we kind of had this array of parameter sets that match the data best, these 2,500 parameter sets, we ran the model out to steady state, to the same point that we used for calibration, and then after that we ran interventions. So the first intervention was household contact tracing. If there's an index case in a house, we looked for other cases in the house, and if there were other active TB cases, they transitioned to the treatment state. The next thing we looked at was household contact tracing plus high prevalence grid cell screening, which basically was we took the prevalence of each grid cell, or in the district was split up into 100 meters by 100 meter grid cells that we used to set up the spatial part of the model, like I had said before, and each grid cell we calculated the prevalence, the period prevalence the prevalence that was used during the time that it was calibrated. So we ran it to steady state. We calibrated it over a 33-month period to match the 33 months in the prospective cohort study, and so over that 33-month period, we calculated the prevalence, and so we used those prevalence values as sort of weights in this additional screening intervention, or spatially targeted intervention rather. So basically, when we're talking about high prevalence grid cell screening, if there's a new case of TB anywhere in the district, then we basically sample a grid to target for spatially targeted a grid cell to target for spatially targeted screening interventions using the prevalence as weights. And then when we selected a grid cell, we looked at between 20 and 100 individuals in that grid cell between 20 and 100 individuals in that grid cell for active cases of TB. And we estimated that was sort of represented a reasonable amount of effort, and was approximately similar to kind of the amount of effort that it would take to do household contact tracing, maybe a bit more, but we kind of and it would also sort of cover sort of a relatively high percentage of individuals in that grid cell, because like I said, the average was about 140. So then in terms of screening interventions, we assessed their impact. So basically the reduction in incidence versus sort of a counterfactual scenario in which there was no screening. And then we also looked at the efficiency, so the number needed to screen to find a new case. Okay, so then we ran a bunch of sensitivity analyses. I won't go into too much detail. I just want to, there's a couple that are kind of important. But so we also looked at, in addition to sort of looking at alternative calibration methods and varying kind of key parameters, we also scaled up the screening area. So instead of in the high prevalence grid cell screening intervention, instead of only targeting one grid cell, we targeted 4 or 16 grid cells. And then we also scaled up the screening area and the number screened. And so in all of these cases, we assessed the efficiency and the impact. So now onto the results. First of all, in terms of calibration, like I said, the goal was really to recreate the sort of the local case intensity in the district and sort of the clustering of cases in the district. And this is a metric that kind of assesses the amount of autocorrelation in a spatial data. Oh, did someone say something? Okay. So yeah. So essentially, this is a metric that quantifies the amount of autocorrelation, the amount of sort of clustering there is in a spatial data set. And so we had, each of these dots represents a resampled parameter set. The best fitting parameter sets. And on the x-axis, we have sort of this metric is Moran's I. So on the x-axis, we have a Moran's I calculated from the simulated case distributions for each parameter set. And on the y-axis, we have data, the Moran's I for the data set. And so the reason why there's only one data set, so you might expect that there would only be one data Moran's I, but when you calculate, but that's not the case. There's obviously more than one, and the reason why is because when you calculate the Moran's I, you have to give a spatial weights matrix. So you have to say how let's say how the grid cells are how they're connected, how they interact with each other, and so to do that for each parameter set. Like I said, we had different parameters, like that theta and that power, that we raised the distance to for the kernel. So we used those parameters for each parameter set in the data set to sort of provide that spatial weights matrix. So we varied those parameters, so therefore we have different Moran's I values for the data. So I should say that these two were, it's not like a one-on-one sort of correspondence, although they're pretty closely correlated. And the R-squared value was 95%. So essentially, we felt like we were able to kind of recreate this autocorrelation in the spatial data. With the array of parameter sets that we resampled. Then in terms of like the epidemiology of the modeled population, we got kind of between 20 and 30%, depending on the number of active TB cases, of course. We got between 20 and 30% of people with having latent TB. We also found that the prevalence of active TB among household contacts of detected cases was kind of in line with this meta-analysis that was done that found it was approximately, I think, 3.1%. We felt like this was a reasonable kind of representation of TB epidemiology. Then on to the results of the interventions. So on the left-hand side is the efficiency, which again is the number needed to screen to find a new case of active TB. And household contact tracing is pretty efficient. So there's a median of these are ridgeline plots which show the distribution of all results. The black bar in each one is the median value. The bottom one corresponds to household contact tracing. The top one corresponds to household contact tracing plus high prevalence grid cell screening. And so so if we're talking about the number needed to screen to find a new case of active TB, looking at household contact tracing alone, we needed a median of 40 individuals needed to be screened to find a new case, which is relatively efficient. This is compared to this high prevalence grid cell screening intervention plus household contact tracing. So it's sort of an incremental assessment where we kind of really lose a lot in terms of efficiency. Again, just to reiterate, this high prevalence grid cell screening is really going to places that had high prevalence and just kind of screening most of the individuals in those places. And by places, I mean grid cells. So yeah, so there's very small localized areas with high prevalence and screening most of the individuals within those localized grid cells. So we lose a lot in terms of efficiency. So this method seems to, we really need to screen a lot of people to find a new case of active TB. On the other hand, if we look at the impact, so basically the incidence reduction, you know, these are rate ratios. So basically, if we look at sort of the intervention intervention plus passive detection incidence over just passive detection. For household contact tracing, we see that there's a median of basically 0.96. So there's a small reduction in incidence of about 4% for household contact tracing only. But then if we look at household contact tracing and high prevalence grid cell screening, there's really not much of an additional impact despite this kind of big loss in terms of efficiency. So I will say, so one thing, an additional point is basically if we kind of stratify the number of people that are screened for a high prevalence grid cell screening intervention. So if we stratify the results by the number of people screened, so I said in this intervention, we screened between 20 and 100 people, but we varied that parameter. So across all simulations, if we stratify by the number of people screened, we see that, so this is efficiency on the left-hand side. We see that as the coverage increases, the efficiency decreases. So and this is again, number needed to screen. So if that in that given parameter set, we screen 100 people for each high prevalence grid cell screening run, the efficiency is lower than if we were to screen 20 people. So we're not really gaining, the efficiency is clearly is decreasing as we screen more people. And basically the impact is essentially the same. I mean, arguably it is higher, slightly higher when you're screening more people. So you do get, I guess, it's just comparing the medians here, you get sort of a median of 1% sort of lower incidence in these simulated scenarios. So I will just talk about two key sensitivity analyses that kind of, I think, solidify the story that or kind of crystallize the story. So first, we scaled up the screening area by we looked at scaling up the screening area by so instead of looking at one grid cell in the high prevalence grid cell screening, we looked at 4 grid cells. We also looked at 16 grid cells, and we did the same. So we did that in terms of efficiency. We also did that in terms of impact, and there's really not a large yeah, a large change in impact at all. But on the other hand, when we increased the screening area and the coverage, although the efficiency we lost we kind of lose in efficiency, we were able to increase the impact. So essentially, the key kind of takeaway from this is the only kind of way we were able to increase the impact was really to increase the number to increase the number of people that we screen. I would also say another sensitivity analysis that actually is in an extra slide, but I'll skip ahead to it. Is if we run out the interventions over 10 years, so the interventions we were running before were over 5 years. If we run the interventions out over 10 years, then we also can increase the impact. So in terms of conclusions, we found that household contact tracing is efficient and confers sort of modest population level reductions in incidence, and basically, but on the other hand, contrary to what's been demonstrated in other modeling studies, targeting areas with high transmission was not efficient, and didn't really confer much additional impacts. Basically, ultimately, we think we observe these limited impacts due to the fact that centroids are quite small, so on average 140 people, and we're screening a relatively small number of individuals per intervention run. So the only sensitivity analysis that resulted in an increase in impact included, the only sensitivity analysis within the 5-year time span that resulted in an increase in impact included scaling up the screening area and coverage. But this came at the cost of efficiency. So overall, this really kind of suggests challenges in using spatial data to inform effective localized screening interventions for TB. So yeah, I'd like to thank co-authors, also the study nurses for their data collection for the prospective cohort study in Lima. So thank you, everyone. Yeah, with that, if anyone has any questions.
Brilliant. Thank you so much, Josh. That's really interesting. And as somebody who doesn't work in the spatial field, quite difficult to get my head around some of those things. So before we go into questions, can I just check my interpretation is right on something? So the bit towards the end where you looked at expanding the number of grid cells and it made essentially no difference, does that mean that it's essentially no different to random almost? So not you said it doesn't add much efficiency, but it almost adds no efficiency to just randomly screening any grid cell in the population.
So I don't know if you can say fully random, because we still use kind of higher prevalence areas as weights. But yeah, essentially it wasn't any. I mean, yeah, when we scaled up the screening area and took we kept the number of individuals that we screened constant, between 20 and 100, and if we did it in this sort of highly localized high prevalence area versus a sort of a less localized, maybe slightly lower prevalence area, there wasn't really any difference in terms of impact yeah.
Okay, thank you. That's really interesting. I see there's a couple of questions. I think they're sort of the same question. I don't know, Jennifer, if you went first, if you want to ask it.
Sure. Thank you very much for that really interesting presentation. I was just curious about the methods used for screening in the prospective cohort, if chest X-ray was used, or is there potential for unobserved cases if people have subclinical TB? Thanks.
Good question. I can tell you in terms of the prospective cohort study, it was largely based on I don't have all the details, but I will tell you that there was basically it was like household contact tracing centered, I guess. So basically, if a new case was found, then household contacts were followed up for, I believe, 12 months. And I mean, I think certainly there is always there's a potential for sort of not diagnosed subclinical cases, especially if they were outside, a house of an index case. Finn, if you're talking, you're on mute.
You'd have thought after 4 years of this, I would have got better at that. Thank you. If anybody has a question, please do raise your hand or just unmute yourself. Otherwise, in the meantime, I'll ask another question which I had, which was I was trying to get my head around risks that people would be facing, and I wondered whether the fact that people in the same household are likely to have the same risks, and potentially, I guess, people within the same grid cell might potentially face a lot of the same risk factors as well. And I wondered what sort of effect that might have, or if that kind of comes out in the wash through your calibration and the transmission parameter at those various different, the dispersal kernel and so on.
Yeah, it's a good question. And questions like this came up during peer review as well. I think really the goal was really of the model was really to look at kind of more spatial elements. And so we didn't really include detailed, demography or other risks. I think certainly, I mean, I imagine those definitely have an impact on the relationships between transmission clusters but really, I mean, the primary sort of driving factor of transmission was basically how we defined how people are connected, and that was sort of based on varying these parameters in the power law kernel that sort of defined the force of infection in the community force of infection, and also population density had sort of a large impact in how the cases were transmitted. But I think you're right. I think another model or could represent that in more detail and probably would yield additional insight. Yeah.
Thank you. And then I see there's something from Raghavan. I don't know if you want to unmute yourself and ask.
Hi. Nice presentation. My question is that can this modeling guide in planning an intervention rather than doing an intervention and check about its efficiency? Because here the intervention was that household contact tracing. What I just want to know is that would this sort of modeling guide and planning interventions, not just household contact tracing alone? So, yeah.
Sorry, just to repeat your question. So you're asking if this kind of model could sort of guide planning of interventions in addition to household contact tracing and like. Yeah. So I mean, so we did. Yeah, we looked at household contact tracing and also we looked at household contact tracing, and then also kind of a more spatially based intervention. I mean, I think. It's a model, so it's sort of one data point, but it is, I think it kind of, I think you can potentially take away from this project that if you're doing kind of spatially based TB screening interventions, the impact might not be very high if compared to just doing household contact tracing alone. So I guess it's just something maybe to consider. If you want to design sort of a spatially based active case finding intervention. I don't know if that answers your question or not.
Yeah, thanks.
Great.
I mean, maybe as a follow-up to that, there's also the other element, which I don't think you included rather, sorry, which was the preventive, if you were looking at preventive therapy or, in the future, vaccines or something.
Yeah.
I mean, that might be something which work different. I suspect you'd have the same sort of answer, right? But I wondered if that's...
Yeah, and so I think I mean, I guess if we looked at, I guess there's like, preventative preventative treatment but I think definitely at least based on this model, I think really the key takeaway that was that if we kind of design kind of smaller scale interventions or more sort of modest level interventions, that the impacts are relatively low. And so I don't know. I mean, it's maybe another kind of direction to include something like preventative therapy, and see, maybe over a longer period of time, it might have higher impacts. But I guess we'd have to sort of run the interventions for a longer period of time as well.
Yeah, actually, that's a really good point. Puneet's asked about the PNAS paper. Is that I don't know if you can see in the chat, is that the same data set, I think is the question there. Puneet, do you want to, I can click on the link and check it.
Maybe I can.
So this is a paper from Chan Chin and Megan Murray's group on spatial scale of TB transmission in Lima, Peru.
Yes, so this is I believe this is the same, the same prospective cohort study data.
If I can ask, maybe I'm still trying to get my head around some of this, but part of me was wondering about, we're modelers, or a lot of us here, I think, are modelers, so we like to use transmission modeling tools. And I think the transmission element helps you to understand who is there, to understand where the distribution of TB disease and infection is in the population. But I was just thinking, once you have that, once you've calibrated your model and you've got to the present day, then you almost don't need the transmission model to think about going forward, because it's really, what you were focusing on was that number needed to screen, which was just an interesting thing, because it made me think, then you can potentially use those kind of tools to just play with and let people that, you've got the distribution data then, and you can just play with it and think about whatever you want to in terms of different approaches. And I just wondered if I'd misinterpreted how that would affect, how that would play out in your model. I mean, I guess obviously it means you'd see a slightly less effective intervention because you don't have that effective transmission averted, but it still, might be a useful tool for just playing and letting people explore themselves. People who are very familiar with the context might say, oh, what if I actually focused on this or that area or something?
Yeah, so I think, I think it's interesting what you're saying. I think, so like the model, I think the model, like if you take any specific run of the model, it won't, probably won't completely recreate the spatial distribution 100% of the time. And I think, I think that wasn't necessarily, like the goal was kind of to derive sort of a more general you know, a more general model that maybe sort of recreate some key kind of criteria in the spatial distribution of cases in Lima. So like, I think if you look at all 2,500 resampled parameter sets together, then you get a nice maybe summary. So maybe if you could, yeah, somehow, you know, plug in, you know, or maybe derive some sort of, you know, like summary metrics from that, then you could maybe use something like that to kind of play around with, maybe. Right?
Yeah, fair enough. I mean, as just a thought. Chell has a question as well. Do you want to unmute? And maybe this is probably the last question we have time for, but do you want to go with your last question?
Yeah, I was just wondering if you would expect similar results if locations other than household were used, like workplaces or other places that might be involved in transmission.
So I think potentially there's a paper on like spillover from prisons. And I think that showed, I mean, it was a study, and it showed that there was, yeah, certainly an effect of sort of TB transmission from you know, from prisons to the community. So I think potentially we might potentially see different, you know, depending on the location and the dynamics and the interaction with the community, we might see, we could see potentially different, yeah, different results.
Thank you.
And in fact, if you're interested in that, Chell, there's I think that was a talk that Yeran Liu gave maybe a couple of months ago, which is recorded on the website, which was, I think, is probably the one you're referring to there, Josh. And in fact, I know Yeran joined for most of the talk and then I think had to drop off. But so I'm sure she'd be interested in chatting about it further if you're interested. I think with that, we'll probably have to go because it's 1 minute to the hour. But thank you so much again, Josh. And thank you everyone for joining us. Next month, we have a talk towards the end of the month. I think it's the 23rd of May, which will be from Andy Iskakis on calibrating complex TB models using history matching with emulsion as well. So hopefully you'll be able to join us then, and look forward to seeing you all soon. Thanks a lot, everyone.
Thank you.